Hello, everyone. I am Mandeep Rana. I am a pediatric neurologist, a sleep specialist, and currently an epilepsy fellow at CHOC Children's. And I will be talking this afternoon about sleep and epilepsy, a common interplay. There is a lot of crosstalk that is between sleep and epilepsy. So it's really an interesting and important topic to cover. All right. So sleep, we spend about 1/3 of our life asleep, and this is essentially not a wasted time because sleep is essential for our mental and physical health. It has a lot of restorative benefits, but also helps with memory, cognition, learning, and has a big impact on our metabolic health as well. So it's important for everyone, and especially for children and individuals with epilepsy. This talk of mine has important aspects that will cover both pediatric and adults, but it's mostly geared towards pediatric patient population. So the objectives of my talk are, I'll go around some of the normal basics for sleep, some of the common sleep disorders that exist in the general patient population and also in individuals with epilepsy, some of the tools that sleep specialists use to evaluate sleep disorders, and then we'll explore the bidirectional relationship between sleep and epilepsy. We'll look at what is the effect of sleep on seizures, epilepsy and EEG abnormalities, and at the same time, what is the effect of epilepsy on sleep? And finally, we'll wrap up with some of the treatment and management strategies. So this is a hypnogram, which basically shows the different stages of sleep that we go through during the course of the night. So there are two distinct sleep stages that we go through. One is the REM sleep, or the rapid eye movement sleep, that is shown in the red horizontal bars here. And the other is a non-REM sleep, or the non-rapid eye movement sleep, which is divided into 3 stages, N1, N2, and N3. N3 is the deepest stage of the sleep, also called as slow wave sleep, and N1 and N2 are the lighter stages of the sleep. And we alternate between these stages in a very cyclical and predictable manner through the night. When we fall asleep in the lighter stages of the sleep, and then gradually descend into the deep stage of the sleep. And then eventually we ascend up and go to REM, and this cycle sort of continues through the night. In a given night, there could be about 3 to 5 cycles of REM sleep, depending upon the sleep duration. And children tend to have a lot more slow wave sleep compared to adults. And the slow wave sleep tends to be more common in the first third of the night, and the REM sleep, or the rapid eye movement sleep, tends to increase in intensity as we go through the night, meaning in the last third of the night. There are some distinct differences between REM and non-REM sleep. They're both equally important from how we feel during the day, meaning the restorative properties and for memory consolidation. But from a neurophysiological standpoint, there are some differences. During non-REM sleep, there is a synchronization of all our autonomic functions, meaning our breathing, our heart rate tends to become very synchronized. As opposed to REM sleep, which is the dream sleep, there is a lot of irregularity in our heart rate, breathing activity, and there are a lot of jerky eye movements, and hence its name. From a brain waves perspective, there is a synchronization of the thalamocortical activity, and thus the non-REM sleep is also called as synchronized sleep. During REM sleep, there is actually a desynchronization of the brainwave activity. And In addition, there is a skeletal muscle paralysis, except for the muscles of our eye and breathing, which are active. Because of the synchronization of the brainwave activity, there is a greater tendency for the propagation of the abnormal electrical activity or epileptiform activity during non-REM sleep. So that's why the epileptiform activity and the seizures tend to be more common during the lighter stages of the sleep and also during the slow wave sleep. Because of the desynchronization of the brainwave activity, in REM sleep, there is a relative resistance to the propagation of EEG abnormalities. Both of these sleep stages are important from a memory consolidation standpoint, but the declarative memory consolidation tends to occur more during non-REM sleep. And this is the type of memory which is the episodic memory for certain events, the semantic memory for facts and concepts, whereas REM sleep is primarily important for the non-declarative memory, which is the procedural memory for the different tasks that we learn during the daytime. This is a consensus statement that was published by American Academy of Sleep Medicine on the sleep requirement in different age groups. As you can see, there is a lot of variability. Of course, it depends upon each child's environmental, genetic, and metabolic and medical condition in terms of their sleep requirement. But infants, for example, require about 12 to 16 hours of sleep in a 24-hour period, and this includes naps as well. And the sleep requirement then gradually decreases over the course of the years, and by the high school age group, children require up to 8 to 10 hours of sleep in a given 24-hour period. And it's important to note that it's not just the quantity of sleep, it's the quality of sleep that's also equally important, meaning having a restful sleep without disruptions or arousals that ultimately leads to a more refreshed feeling during the daytime. So let's look into some of the common sleep disorders that are out there. One of the common sleep disorder is obstructive sleep apnea, which is characterized by an increased resistance of our upper airway during sleep. And this results in an intermittent closure, whether that's partial or complete, of our breathing tube. And the individual continues to breathe or makes an attempt to breathe on that closed breathing tube. And this can eventually lead to sleep fragmentation or sleep disruption and some changes in our gas exchange abnormalities, meaning drop in oxygen levels or elevation in carbon dioxide levels. Some of the common symptoms of obstructive sleep apnea are snoring, gasping, choking at nighttime. Children can often be very restless at night if they have obstructive sleep apnea. They can sleep in funny positions, which is an attempt to be in a position that's most comfortable to them, and they can breathe better at night. And some of the daytime symptoms include waking up with a dry mouth, morning headaches, feeling tired during the daytime. Young children in particular, if they are not sleeping well at night, they tend to be more hyperactive, and it can masquerade the symptoms of ADHD. They can have difficulty focusing or concentrating in school as well. Some of the common causes for obstructive sleep apnea in children, most common cause being large tonsils and large adenoids, what we call as adenotonsillar hypertrophy. It could also be because of some craniofacial abnormalities, and common example being children with trisomy 21, achondroplasia, Pear band sequence, and obesity, of course, is an important cause as well. Abnormalities in the muscle tone can also be a risk factor for obstructive sleep apnea. So, for instance, children with cerebral palsy or other genetic conditions where there is actually low muscle tone. And these abnormalities in the tone makes the upper airway or the breathing tube a lot more collapsible when children are sleeping at night. And there are other factors, which include certain genetic and hormonal factors that can affect and be a risk factor for sleep apnea as well. Other common sleep disorders include insomnia, which is difficulty falling asleep or staying asleep, or it could be a combination of both. And when this is present, it of course leads to a decreased duration of the total amount of sleep in 24 hours. Restless leg syndrome, which is a compulsive urge to move the legs, and this is especially brought on by rest. And there is often a circadian propensity, meaning the symptoms tend to be more common during the evening hours or close to the bedtime, especially when the child or patient is laying on the bed, not moving that much. Excessive daytime sleepiness is another common sleep problem, which could be either because the nighttime sleep is fragmented or disrupted, or there is not enough good quality sleep, or it could also be secondary to a primary sleep disorder like narcolepsy, for instance. Sleep-related rhythmic movement disorders or periodic leg movements of sleep is another problem, which is associated with repetitive leg movements in sleep that again can cause disruption to the nighttime sleep because it leads to frequent arousals during nighttime. Parasomnias are undesirable behaviors or sensory feelings that can occur both during non-REM and REM sleep. The common non-REM parasomnias are sleepwalking, sleep talking, night terrors. And night terrors especially can be sometimes be a little bit of a challenge because it can pose a diagnostic dilemma in between seizures and night terrors. And oftentimes children can look very terrified. They can have their eyes open but not responsive. They can have some color changes. And the next morning, in majority of the cases, children usually don't have a memory of these events. REM parasomnias primarily include nightmares where the child actually oftentimes wakes up with a bad dream and is able to completely relay what they saw or what they experienced. The other uncommon type in pediatric patient population of REM parasomnia is REM behavior disorder. This is more commonly seen in adults. It is basically where individuals tend to act out of their dream quite violently, leading to injury either to themselves or to the bed partner. It's rare in children, but can be seen in conditions like narcolepsy, rarely. Circadian rhythm disorders. There are different types of circadian rhythm disorders, but the one that is of most relevance, especially in children with epilepsy, is the irregular sleep-wake cycle disorder, where sleep is actually distributed across the 24 hours, and children fail to take a consolidated number of hours of sleep at nighttime, but it's distributed in 2-hour chunks and an hour chunk across 24 hours. There are several tools that the sleep specialists can use to evaluate sleep problems. Besides taking a detailed history, tools like Epworth Sleepiness Scale, which is something that looks like this. It's just a set of 8 questionnaires that helps you rate what is your likelihood of falling asleep in some of the common situations listed here, like sitting and reading, sitting and watching TV or a video. And then when you sum it up, you calculate a score. If the total score is more than 10, it would suggest some daytime sleepiness. And if it's more than 16, it would suggest a very high level of excessive daytime sleepiness. And when that's the case, it needs to be further looked into details, what the cause for that might be. This is one of my favorite tools. It's a sleep diary that can be easily downloaded from the American Academy of Sleep Medicine website. It basically lists 24-hour day where you can chart when you went to bed and what time you fell asleep. Or a parent can actually do that for their child as well, and also mark the times during the day where the child took the naps. And this just gives a good visual impression as to what the sleep cycle looks like over a course of 2 weeks or 3 weeks time period. Because it is subjective, so there is some potential for bias, but it's actually a very easy way to look at the sleep-wake cycle. This is an actigraphy. This is more of an objective test, and it is like an accelerometer in our iPhones. It can be worn on the wrist or around the ankle. And what this instrument does is it measures or gives us the markings when an individual or a patient is awake, and when the patient is sleeping or is lying still in the bed, there is essentially no marking. So it helps by proxy, gives us an impression when the individual was asleep and the timings when they were awake. So very good tool to look at the sleep-wake cycle over the course of past couple of weeks, and also helps us in assessment of circadian rhythm disorders. A sleep study or polysomnography is the gold standard to assess for most medical sleep disorders. And a common indication, of course, is when there are symptoms of obstructive sleep apnea, snoring, gasping, choking, restless sleep, and so forth. It's also a good tool to assess for hypersomnia if the child has excessive daytime sleepiness, especially for conditions like narcolepsy. And if there are nighttime events, parasomnias, where the nature is not entirely clear, whether they are seizures versus parasomnias, and of course to assess for excessive periodic leg movements of sleep. It is, however, not indicated if it's very clear by history that the nocturnal events are parasomnias. And in that situation, sleep study might not be of much value unless there is a concern that there is sleep fragmentation from other sleep disorders that might be worsening parasomnias. So sleep study might be indicated in that. If by history it's clear that a patient has circadian rhythm disorder or insomnia or restless leg syndrome, sleep study is not much of help there either. This is a typical setup of a sleep study. We have very limited EEG leads, less than what the conventional EEG looks at. And this EEG basically helps us understand if a child is awake or asleep, and if asleep, what stage of sleep the child is in. We also have the eye leads that help us look at the eye movements, and all the stuff that you're seeing in the front helps us measure the breathing portion during sleep. We also have a little microphone that helps us assess for snoring, and the child also wears the belts that helps us look at the respiratory effort. There are also some stickers or leg leads, what we call, that helps us look at the leg movements, and there is a small pulse oximeter that's placed on the finger to help us look at the oxygen levels. This is a 60-second picture of what a normal sleep study epoch would look like and what the sleep specialists look at: EEG, leg leads, all the measures for the respiration or breathing, EKG, oxygen levels, and then the carbon dioxide levels. So now looking into the next question, how does sleep affect epilepsy? Sleep from a brain perspective, from an EEG perspective, is characterized by a lot of rhythmic activity or a lot of oscillatory activity in brain. And especially during non-REM sleep or non-rapid eye movement sleep, this rhythmic activity is highly synchronized. And because of this synchronization, there is an activation or potentiation of the epileptic form activity. And there are several studies that have looked at it and shown that the epileptiform activity is most common during non-REM sleep. And when compared between different stages of non-REM sleep, The epileptiform activity is most common during the deeper stages of the sleep, although it is still seen in N1 and N2, meaning the lighter stages of sleep. And it's very little that we actually see during REM sleep because of the desynchronized brainwave activity. And similarly, seizures tend to be more common during non-REM sleep, more so during the lighter stages of sleep, N1 and N2, less so during the deep stage of the sleep, and least during REM sleep. We also know that about a third of the epilepsy syndromes that we see in children tend to occur either during sleep or upon sleep-wake awakening or sleep-wake transitions. A common epilepsy syndrome like Rolandic epilepsy tends to occur out of sleep. Some of the common benign epilepsies like Pathophysiology syndrome, also called childhood epilepsy with occipital paroxysms, seizures tend to occur more commonly in sleep. Epilepsy previously called as nocturnal frontal lobe epilepsy, now called as sleep-related hypermotor epilepsy, tends to occur out of sleep as well. Infantile spasms or epileptic spasms tend to cluster at sleep-wake transitions, so they're more common during around nap time or in the early morning hours upon awakening. And juvenile myoclonic epilepsy is another classic example that where the seizures, myoclonic seizures, tend to occur upon awakening in the morning. And Landau-Kleffner syndrome is a condition where there is language regression or regression in other developmental domains, but on the EEG, it is characterized by continuous epileptiform activity or continuous spike wave patterns during sleep. And this activity might be minimal or none during wakefulness. So there are a number of examples of different epilepsy types that tend to be more common during sleep. And sleep deprivation in and of itself has been shown to activate abnormal EEG activity. And not only it activates EEG activity, it has been shown that it makes seizures more likely in individuals or patients with epilepsy. The question is whether this is a genuine activator or it acts just as a way of sleep induction. And when comparing drug-induced sleep with sleep deprivation-induced sleep, it was found that there were more epileptiform activity in sleep deprivation, meaning the sleep that was induced after sleep deprivation. And the awakening EEG after sleep deprivation had more epileptiform activity versus the sleep EEG after sleep deprivation. So it's really an independent activator, and that's one of the rationale that sleep deprivation is used when we're doing our either routine EEGs or EEGs in the epilepsy monitoring unit. What is the effect of circadian rhythm on seizures and epilepsy? Just to understand what circadian rhythms are the endogenous or internal 24-hour rhythms that we all have as living beings or living individuals. And circa means around day, and diem is day. So the rhythms that occur around the 24 hours. And these circadian rhythms control a lot of our biological functions, which includes secretion of certain hormones, our body temperature, our digestive processes, and of course, sleep is one of the process that is under circadian rhythm control. And this is shown by some of the evidence that we have. So in this graph, these dark bars indicate the times of sleep, and the white ones are where the individual is awake. So we know that our body temperature usually dips or is at its nadir a couple of hours before we wake up in the morning, and it tends to rise as we are awake during the day. And this tends to follow a typical pattern, which is under circadian control as well. So the cortisol levels in our body tend to peak when we are waking up in the morning. It has another peak in the afternoon and then tends to dip when we are asleep. Again, a circadian a process under circadian control. And similarly, melatonin, which helps us with sleeping, tends to be at a lower level all through the day, but it gradually begins to rise a couple of hours before our habitual sleep time, and is at its peak a couple of hours before we actually wake up. And the relationship between circadian influence and seizures have been long known, but we have been able to recognize this influence a bit more closely because of the patient diaries and the EEG monitoring that we have been able to obtain, and has documented this relationship more strongly. It can be difficult at times to separate how much of this relationship is actually with the sleep versus circadian rhythm. But it's been shown that that there is some relationship between the area of the brain the seizures arise and its influence on the time of the day that these type of seizures tend to occur more. So seizures arising from the frontal lobe have a propensity to occur most commonly during sleep. So on the x-axis is the time. So the ones that are shown in the red here are the frontal lobe seizures. The seizures arising from the medial side of the temporal lobe, also called as mesial temporal seizures, have shown to have two peaks. The first peak, or the primary peak, being between the late afternoon, and the second peak being in the later time of the nighttime or early morning hours. Whereas the seizures arising from the neocortical temporal region tend to have a peak more in the morning hours. So this is something it's been shown in terms of the area of the brain from which the seizure originates, that circadian influence does play some role there. The exact understanding or the explanation behind this is not clear. The thought is that perhaps the excitability in the brain, particular area of the brain, follows a circadian pattern, and that's why we tend to see this kind of a relationship. Looking into the other part of the question, how does epilepsy affect our sleep? This has been documented in several studies that the overall sleep architecture is affected in patients who have epilepsy, especially those whose epilepsy is not very well controlled. And it's been seen that there is an increased sleep latency, meaning that it takes much longer for patients or children who have epilepsy to fall asleep. They have decreased sleep efficiency, meaning the amount of the time they're actually able to fall asleep is less than the amount of the time they are actually in the bed. They have higher sleep disruption, meaning their arousal index is quite high during the night, meaning they tend to wake up more during the nighttime. And whether that is because of the epileptiform activity or seizures or effect of medications or effect of comorbid sleep disorders, all of that sort of play a role in that. The other two important things that have been documented is that they have less slow wave sleep, and slow wave sleep is the sleep that actually gives the feeling of restoration in the morning. And they also have less REM sleep. And REM sleep is important for a number of factors, including our memory as well. The other thing that's been shown is that there are increased number of stage shifts, which sort of goes along with that. They have increased sleep disruption or increased arousals that would lead to increased stage shifts. The other piece of epilepsy is that the medications also have some impact on our sleep architecture. The effect of different medications have been very variable, and they affect sleep in different ways, and this can also vary from one patient to the other. Some of the consistent effects that have been shown is medications like benzodiazepines tend to decrease our slow wave sleep. Medications like gabapentin, pregabalin, carbamazepine, Depakote tend to increase our slow wave sleep. And similar medications along with clobazam and carbamazepine tend to decrease the amount of time that it's taken to fall asleep, so easier time falling asleep. Lamotrigine, which is one of the newer medications, relatively newer, it's been out there for some time, has also shown to have some favorable effects on sleep, meaning it increases REM sleep and it decreases the arousals and the stage shift. On the other hand, it can be very activating for some patients. So patients can actually have difficulty falling asleep while they're on lamotrigine, but overall, its impact is shown to be quite beneficial on sleep. So the other aspects that have been looked at are what is the impact of epilepsy surgery on sleep? And some of the studies have shown that there was an increase in the total duration of sleep time, especially in those patients where the seizures were effectively treated post-surgery. Vagal Nerve Stimulator, which is a device that is used to help with patients with treatment-resistant epilepsy that's implanted under the skin, and it produces or it activates the vagal nerve in the neck. Has also been shown to improve the daytime sleepiness and increase the slow wave sleep. There's just a small data that's present for ketogenic diet where it is shown to increase the REM sleep. So understanding of some of these medications is important because the clinicians can base their choice not only on the type of epilepsy syndrome, but also on the effects that a particular medication can have. So for example, if a patient has insomnia, medications that would help additionally with sleep can be chosen. One thing I would like to highlight here that vagal nerve stimulator, we know that can be very beneficial, but it can also produce sleep apnea or sleep disordered breathing, especially in children and individuals who have an underlying tendency for sleep apnea. So if a child has an underlying sleep apnea present with the implantation of vagal nerve stimulator, it may become worse. Or if somebody had that tendency, that can also be aggravated with vagal nerve stimulator. So something to keep in mind and watch for daytime symptoms once the vagal nerve stimulator is implanted. And this is an example of how we can see on the sleep study, if somebody had a vagal nerve stimulator, this is around the time when the vagal nerve stimulator is firing. We can see that there is a drop in the air that enters our airway. Breathing effort becomes a bit more shallow, and it can be associated with drop in oxygen saturation. And if these events happen multiple times through the night, every time the vagal nerve stimulator is firing, it leads to an increase in arousals, obstructive sleep apnea, and hence daytime symptoms. The other aspect to look at is how common are sleep disorders in patients with epilepsy. This was a questionnaire study that was completed by parents of children with epilepsy, and they reported the cases are shown in black and the controls are in the gray bars here. So parents reported a much higher percentage of sleep disordered breathing, parasomnias, excessive daytime sleepiness in children who had epilepsy compared to those who did not have epilepsy. And this was also a questionnaire study that was completed by patients themselves who had epilepsy, and they reported a large percentage of sleep disturbance and suboptimal sleep and overall poor sleep in those questionnaires. And just for some comparisons in terms of numbers, the overall prevalence of obstructive sleep apnea is about 1 to 4% in general patient population. However, this prevalence is much greater in patients with epilepsy. So Obstructive sleep apnea in adult patients with epilepsy, the prevalence is about 10%. Pediatric patients is much greater, 20 to 38%. And in patients who have refractory epilepsy, meaning the epilepsy that's been difficult to treat, it's up to 30%. Other sleep disorders like feeling excessively sleepy during the day is also very common in patients with epilepsy, and sleep difficulties, falling asleep or staying asleep, is also a big number. Some of the factors that have been shown that could be contributory to a number of these sleep disorders that existed with a much greater prevalence is it could be medication effect or comorbid anxiety or depression, or just the general lifestyle, because individuals or children who have refractory seizures are not very active, that can further lead to weight gain and further increasing their risk of obstructive sleep apnea, or the seizures themselves or the epileptiform abnormalities themselves can disrupt the nighttime sleep, causing increased arousals and overall sleep disruption. This has been shown in a number of adult studies that when sleep apnea is treated, it leads to favorable outcome from a seizure control standpoint. But this has been shown in pediatric studies as well, that independent of making any changes in their anti-seizure medications, treatment of obstructive sleep apnea led to an improvement in the overall seizure control. This was a study that had about 9 patients, and in about 6 patients, there was a remarkable seizure improvement just with the treatment of obstructive sleep apnea. So if we were to sum up this relationship, both sleep and epilepsy have been called as unfortunate bedfellows, because a lot of factors from sleep and epilepsy can feed into each other and lead to unfavorable daytime consequences. So the anti-seizure medications that we use for control of seizures can affect sleep and cause sleep fragmentation. We know that sleep disorders have a much higher prevalence in patients with epilepsy that can also cause sleep fragmentation. And sleep fragmentation by itself can lead to overall reduction in total sleep quality and can be an activating factor for seizures per se. And at the same time, the nighttime seizures can then lead to sleep fragmentation, ultimately producing some daytime consequences like excessive daytime sleepiness, adverse effects on learning and behavior, and reduction in quality of life, not only for children, but also for their caregivers and families. So in pediatrics, we have this philosophy that we not only care for our children, but also for our families. And this was nicely demonstrated in this study that looked at the impact of pediatric epilepsy on sleep patterns and behaviors in children and parents. So in this study, the parents of children with epilepsy completed a questionnaire about their child's sleep patterns and habits and about their own sleep patterns and habits. And this was compared to the questionnaires completed from children without epilepsy. And what was demonstrated that children with epilepsy, they were more likely to co-sleep with their parents. There was a greater likelihood of parasomnias, sleep difficulties with bedtime resistance, excessive daytime sleepiness, and a lot more nighttime awakenings. And when looked at the responses completed by the parents themselves, it was seen that a large number of parents felt concerned about their child's nocturnal seizures, and about 44% of parents actually felt rarely rested or never, and reported increased fatigue and sleep dysfunction. So this really brings us to a closure that it's really important if your child has epilepsy and has a comorbid sleep problem to really look into the details and try to flush out all the details and to understand what is the type of sleep disorder that we are dealing with. And this would involve taking a detailed history, including the medications, comorbid conditions, looking into some of the other factors that can be responsible for nighttime awakenings as well. And then trying to understand the extent of the sleep problem by filling out some of the sleep diaries and Epworth sleepiness scale. And of course, obtaining some of the other tests like sleep study, actigraphy, or even the medication levels, which can cause excessive daytime sleepiness if they are checkable. Looking at the ferritin level, which can often be low in children who have excessive periodic leg movements of sleep and can cause sleep disruption. Checking some of the hormone levels like thyroid stimulating hormone for hypothyroidism, which in addition can also cause daytime sleepiness or fatigue. And if you're suspecting a condition like narcolepsy, and if the child is young who cannot participate in testing like multiple sleep latency tests, checking orexin level or hypocretin level in the cerebrospinal fluid is something that can be considered. From our other management options, optimal seizure management is important to have undisrupted or minimally disrupted sleep. So paying close attention to the dosing of the medication, the timing, the side effects, and of course the levels, looking at other comorbid conditions, and treatment of the associated sleep disorder. In children, because the common cause of obstructive sleep apnea is large tonsils and large adenoids, so undergoing tonsillar adenoidectomy can be helpful. In older patients, if the tonsils and adenoids are not large, but there is still significant obstructive sleep apnea, CPAP can be an option. Iron supplementation if there is low iron level or low ferritin level. We rarely recommend hypnotics or sleep enhancing medications in children who have sleep difficulties, because behavioral factors do play an important role. But there are situations when we do use sleep enhancing medications as well. And if a child has vagal nerve stimulator and there are concerns that there is worsening of sleep apnea, then certain modifications can be made, especially with the newer models that we have. If a child does not have seizures at nighttime and turning off the VNS at night, or modifying the settings for VNS at night, if clinically we are able to, could be an option. So changing the current output, for example, or the time that the vagal nerve stimulator is on for, or even the frequency settings can be modified to alleviate the sleep apnea that can be triggered by vagal nerve stimulator. And for younger children, especially, making sure that they have the right kind of sleep environment with a consistent bedtime and wake routines, minimum or avoiding naps during the daytime, especially 4 hours prior to bedtime, can often be helpful. And other measures like faded bedtime or even stimulus fading, where the parent actually tends to gradually increase the distance from the child's bed, or even the response time to the child for their nocturnal awakenings. All of these can be helpful if there is a big behavioral component to the sleep problems. So some of the takeaways, sleep and epilepsy do have a bidirectional relationship. Poor sleep and sleep deprivation may trigger seizures or worsen seizure control. There is a high prevalence of sleep disorders in patients with epilepsy. Appropriate identification and treatment of sleep disorders can improve seizure control. Effective treatment and management of seizures can in turn improve sleep. And if a child has epilepsy and sleep problems, of course, consultation with appropriate specialists in this complex relationship or complex interplay can be beneficial to the child. That is all that I had to say. And I will be very happy to take any questions on this topic. So there is a question in the chat. What is TST? So TST is the total sleep time that a child or an individual would sleep at nighttime. And the other question is, what is N2? So N2 is the non-REM sleep. Non-rapid eye movement sleep is divided into 3 sleep stages, N1, N2, and N3. N1 and N2 are the lighter stages of the sleep, and N3 is the deep stage of the sleep. N1 and N2 are the stages where the epileptic form abnormality or the abnormal electrical activity tends to be more common, and seizures tend to be more common. Other questions? You can put them in the chat, or feel free to ask.
I have a question. My grandson seems to wake up most nights after about 5 hours of sleep, and he'll stay up for like 3 hours before he'll fall back to sleep, with or without a seizure.
He does not have a seizure?
That's no, he does not have a seizure. Mm-mm.
Mm-hmm.
I mean, he has epilepsy. They have not defined what type yet, but that's his sleep pattern lately.
Mm-hmm. Yeah, so that would be consistent with what we would call sleep maintenance insomnia, where he's able to fall asleep, but then has difficulty staying asleep. And that could be due to a number of reasons, either, what his daytime pattern in terms of naps is, yeah. So it could be dependent on a number of factors, and the medications he's taking. If he has other sleep problems at nighttime that actually lead to that awakening, that would be another thing to be looked into. Yeah, so this would be a kind of condition that you would need to speak to your doctor to understand, what is that is causing his nighttime awakening, and to sort of work around that.
He has had a sleep study which didn't show anything specific either. So thank you.